Hello, I'm Dr. Milda Chmielowskaite, and today I'll be presenting on the characteristics of patients that did and did not receive surgical treatment for trigeminal neuralgia. This is a large population-based study on 79 million patients. Trigeminal neuralgia is a debilitating chronic pain condition characterized by lancinating paroxysmal pain of the trigeminal nerve. It can have a severe impact on patients' quality of life and functioning. First-line management includes pharmacotherapy with anti-epileptic medications such as carbamazepine or oxcarbazepine. However, individuals refractory to pharmacotherapy may require surgical intervention. Factors such as insurance status, race, and gender are known to influence healthcare choices. However, such demographic factors related to whether or not individuals receive surgical treatment for trigeminal neuralgia have not been explored. Thus, we used aggregated electronic health record data from dozens of healthcare systems to study and describe the demographic factors and treatment patterns of individuals with trigeminal neuralgia who did and did not receive surgery. Our database that we used was de-identified data and a commercial base called Exploris Incorporated. It is aggregated electronic health records of 79 million patients from 26 major US healthcare systems, representing almost 22% of the US population. It has been collected between 1999 and January 29 of 2022. We had inclusion criteria for trigeminal neuralgia, that is, you can see on our abstract poster. And we also created a cohort that did and did not receive surgical intervention for the condition. What we did was we explored the demographic factors such as sex, age, race, insurance type, age at time of surgical procedure for trigeminal neuralgia, medications ever taken for trigeminal neuralgia, the type of surgery that they received, and years from their first prescription of carbamazepine to the first surgery for trigeminal neuralgia. We described these using frequencies. We also did a chi-square test of independence to examine the relationship between demographic factors of sex, race, and insurance status, and surgical status. Some of our findings include an annual incidence of trigeminal neuralgia in 2021 of 19.3 per 100,000 persons. This is consistent with the literature. About 2% of trigeminal neuralgia patients received surgery, at least one or more. Of these, 86% were Caucasian and 9% were African American. The median age of those receiving surgery was 69.3 compared to 67.2 years old for those that did not receive surgery. And for the median age at the time when they had their first surgical procedure was 63 years old. We also found that there was a relationship between sex and surgery, which was significant, and that females were less likely to receive surgery than males. The relationship between race and surgery, however, was not significant. But the insurance status and surgery was, meaning that individuals on private, Medicare, or self-pay insurance were more likely to receive trigeminal neuralgia surgery, and Medicaid were slightly less likely to receive surgical treatment. Of those receiving surgery, 66% had private insurance, 18% were self-pay, and 57% had private insurance for those that did not receive surgery, and 12% were self-pay in those without surgery. The most common surgery was decompression of the trigeminal nerve, and 41% had surgery within 1 year of their first ever prescription of carbamazepine or oxcarbazepine, and 69% had surgery within 5 years of one of those prescriptions, of starting one of those prescriptions. These are just the initial findings, and we believe that additional analyses are warranted to explore questions into whether or not and how sex, race, and insurance interact to create the differences seen between those having surgery for trigeminal neuralgia and those that do not. We're also interested in further exploring treatment pattern differences based on demographics, such as stratifying those treatment pattern differences based on sex, as well as race and insurance status. This project was supported by the Clinical and Translational Science Collaborative of Cleveland, which is funded by the National Institutes of Health, National Center for Advancing Translational Science, Clinical and Translational Science Award Grant, UL1TR002548. This content is solely the responsibility of the authors and does not necessarily represent the official views of the NIH. Thank you for your time.